So good morning, everyone. This is Leslie Lieberman. I am the Senior Director of the Training and Organizational Development Department at the Health Federation of Philadelphia, where I also coordinate the Mobilizing Action for Resilient Communities, or MARC initiative, along with my colleague, Claire Reedy, who is also in the room with me for both moral and technical support this morning. So thank you, Claire. And we are delighted to bring today's webinar to you, Making Meaningful Change, Addressing ACEs Through Public Policy. Before we get started, I have a couple of notes. All participants are muted and will remain so throughout the webinar, but we do want to encourage dialogue. So at any time, you can make comments or ask questions in the chat box, which is located at the bottom of your screen, or you can use the Q&A feature, which is also there. And among other things, it allows you to ask questions anonymously if you wish to. We'll do our best to address all of the comments and questions at the end of our speaker presentations. Also, the session is being recorded, and it will be archived on the MARC website, and everyone who is registered will receive a link to the recording and slides when they become available. So Mobilizing Action for Resilient Communities is a national effort working to unlock and leverage the power of cross-sector networks that are using the science of ACEs, trauma, and resilience to build just, healthy, and resilient communities. For short, we refer to these groups as ATR networks. MARC is supported by the Robert Wood Johnson Foundation, and you can learn a great deal more about us and take a look at a lot of resources that we have on the MARC website, marc.healthfederation.org. You can connect with us at marc@healthfederation.org and follow us on Twitter at healthfedmarc. We're also really delighted that today's webinar is co-sponsored by 4 initiatives with complementary missions and goals to those of MARC: Children's Trust of South Carolina, ACEs Connection, the Center for Community Resilience at the Milken Institute School of Public Health, and the Campaign for Trauma-Informed Policy and Practice, or CTIP. Thank you to our co-sponsors for helping to spread the word about today's webinar and for your ongoing work to advance the ACE trauma-informed and resilience movement. If you aren't familiar with any of these initiatives, I urge you to visit their websites after the webinar. Now it's time to introduce today's speakers. My 3 wonderful colleagues who, through their innovative, thoughtful, and provocative research and practice, are really leading the way to policy changes that address ACEs. First, we'll hear from Dr. Jonathan Purtle, who is an assistant professor of health management and policy at the Center for Population Health and Community Impact at Drexel University Dornsife School of Public Health. There, he is a policy dissemination and implementation researcher who focuses on issues related to mental health and health equity. Next will be Dr. Aditi Srivastav, who is the Director of Research at the Children's Trust in South Carolina. Aditi leads mixed methods research efforts on adverse childhood experiences, race, equity, and community mobilization, as well as examining policies, programs, and practices that improve family and community resilience. She also oversees the South Carolina ACE initiative and manages the Kids Count project. Last, we will hear from Dr. Wendy Ellis, who is the Director of the Center for Community Resilience at the Milken Institute School of Public Health at George Washington University. Her research focuses on designing a strategic approach for multiple systems to align their resources, programs, and initiatives with community-based partners in order to address adverse childhood experiences and adverse community environments. Jonathan, before I turn it over to you, I'm just going to say a few more words about today's topic, which is clearly of great interest to many, as demonstrated by the more than 550 people who registered for this webinar, which is great because policy and advocacy work needs many voices. The good news is that work to prevent and address ACEs at the policy level is steadily growing. In a January blog, Elizabeth Prewitt of ACEs Connection reported that in 2019, 35 laws and resolutions in 20 states were enacted, and prior to 2019, there were nearly 60 statutes. The image on this slide is a very cool tool that you can find on ACEs Connection. In dark green, it shows all the states that have ACE and trauma-informed policies or resolutions, and it's interactive. You can click on the state and find out more about what's going on there. And this only represents state-level work. We know that there is a lot of and growing activity at the local jurisdictional level in all types of communities. Another indicator of the growth of ACE's policy efforts is CTIP, the national nonprofit founded in 2015 to advance trauma-informed policies. CTIP has just launched a new campaign to address childhood trauma and build resilience by engaging and educating Congress. And you can learn more about that effort on their website. The other good news is that all of the initiatives involved in today's webinar have developed free informative resources and tools to help demystify the advocacy and policymaking process and provide concrete steps for how individuals, groups, and communities can become ACE trauma and resiliency policy advocates. As I mentioned before, at MARC, we're particularly focused on how the power of cross-sector ACE trauma and resilience networks can be leveraged. We've seen lots of growth and great potential among these groups to advocate for and inform ACEs and trauma-informed policies at all levels. Last year, we compiled our learnings from our interaction with many of these networks in our toolkit, Mobilizing Action for Resilient Communities Through Policy and Advocacy, which you can find on our website. The toolkit includes a broad definition of what constitutes ATR policy, making it possible for ATR networks to work on a wide range and types of policies, from primary prevention to clinical intervention, and to connect with other groups interested in these issues. It also includes an in-depth look at the various roles that networks can play to promote and advance ATR policy and advocacy activities. And it includes case studies and references to other valuable related resources. We hope that you'll take a look at it very soon. And now I'd like to turn it over to our first speaker, Dr. Jonathan Purtle.
Hey everyone, thank you for joining this morning or early this afternoon, depending on where you're at. So in the next 20 minutes or so, I'd like to share some research that I've done here with colleagues at Drexel related to public opinion research and policymaker opinion research, really focused on ACEs and generating knowledge to help communicate how we help inform how we communicate ACE science to the public and to policymakers. So this work is really at the intersection of the massive and growing evidence base about adverse childhood experiences, public policy, public opinion research. We know that public opinion influences public policy, and communication and dissemination research. So what I'm going to present is really at that intersection. And I'm going to quickly go through two distinct but somewhat related studies. The first one is from a survey of US state legislators we did about their opinions about ACEs as risk factors for adult mental health and substance use conditions, i.e. behavioral health conditions. And the second study is data we have and recently collected about public opinion about adverse childhood experiences. So this is the first study. It was published in Psychiatric Services over the summer. It is not open access yet. It will be in about 6 months, but if you email me, I'm more than happy to send you a copy of the article if you want to read more about what I'm going to present today. So I'm probably preaching to the choir a bit here, but state legislators, of which there are over 7,300 in the US, are a really important audience when it comes to ACEs. They make decisions through writing laws and voting on laws that can prevent ACEs and mitigate their effects, and unfortunately could also probably increase ACE exposure and make their consequences worse. They're an important audience. They make decisions about the allocation of tax revenue. They regulate public services and systems, and of course, they also very macro affect the social determinants of ACEs and the social determinants of health. The National Conference of State Legislatures put out a great report back in August 2018 that's all about specific ways that state laws can help address ACEs. So I won't reiterate those here, but a great resource for folks who may be interested. And we also know from the ACE science that ACEs are risk factors for people having mental health and substance use disorders in adulthood. So this first study, there's a ton of literature on this. Just to pull out two things that are particularly relevant. This was a systematic review and meta-analysis published in the Lancet Public Health. Reviewed, I think, 30 studies were brought into the meta-analysis and compared to adults with 0 ACEs, those with 4 or more ACEs had 4.4 times higher odds of depression, about 6 times higher odds of problematic alcohol use as an adult, 10 times higher odds of problematic drug use, and about 30 times higher odds of attempting suicide as an adult. An older study, but also a very good study using data from the National Comorbidity Replication Survey. They looked at 3 ACEs, sexual abuse, physical abuse, and witnessing domestic violence, and calculated the population attributable risks for those different ACEs. And they found that those 3 ACEs together accounted for about 27% of all mood, anxiety, and substance use disorders among adult females, and 24% of those among males. So again, this is stuff we know. We know that there is this connection between ACEs and adult behavioral health issues, which really just, one of many reasons underscoring the importance of preventing ACEs and mitigating their effects across the life course. So given the potential of state legislators to address ACEs, we wanted to know, well, what do legislators think about ACEs? So we wanted to describe their opinions about ACEs as risk factors for adult behavioral health conditions, and also identify how these opinions varied by legislators with different characteristics, particularly their ideology. So looking at conservative, liberal, and moderate legislators and seeing how their opinions differ. These survey questions, we kind of snuck in to a much broader survey about mental health that was funded by NIH. So, if the survey was solely focused on ACEs, we would have asked a ton more questions, but we were able to kind of just sneak these 5 questions in there, and that's what I'm going to present on today. So we did a survey of US state legislators in 2017. And the survey was really just focused on legislators. We said in the recruitment materials that we wanted the legislator to complete the survey and not their staff. We really wanted to get their opinions from the legislators themselves. We post-mailed them the survey, we emailed them, we called them, we did everything we could do to get them to try to complete the survey. And we got a response rate of 16.4%, which is lower than what we hoped for, low by public opinion research standards, but turns out to be the highest response rate anyone's gotten of legislators in the past 5 years or so. The good thing is that we knew about respondents and non-respondents in terms of their political party, their gender, and their geographic region, and we were able to see if and how respondents and non-respondents differed on those variables, and they actually weren't that different. So we feel pretty good about the representativeness of our sample with these 475 legislators who completed our survey. So the dependent variable here, what we were really interested in, we asked legislators to what extent they thought that each of the following events, when experienced as a child, increases a person's risk of developing a mental illness or substance use disorder as an adult. And 1 was low risk increase, 5 major increase. And we picked these 4 ACEs: childhood sexual abuse, physical abuse, witnessing domestic violence as a child, and childhood neglect. We would like to know about more. We were limited to just fitting 4 in here, and we picked these because they represent both direct and indirect exposures, and also violent and non-violent exposures. So when I'm going to present, we dichotomize these variables as whether or not the person said 5, major increase, yes or no. In sensitivity analyses, we also looked at them as continuous variables and looked at means, and we found the same thing, and the data tell the same story. And independent variables, we asked them if they had ever heard of the ACE study, and gender, political party, ideology, looking at how opinions varied across those different characteristics. And what I'm going to present, I'm really just going to focus on the ideology. The other stuff is in the paper. I'm happy to share with you. So what % of state legislators had heard of the ACE study? 33%. Is that good or bad? I'm not sure. I guess it depends who you ask. I thought 33% was pretty good. It was higher than I had thought. And yeah, I think it's worth noting, we started fielding the survey back in March of 2017. That's about 3 years ago now. So perhaps it could be quite higher today. So more liberal and moderate legislators had heard of the ACE study than conservatives, which I didn't find particularly surprising, but this does signal our advocacy efforts and ACE evidence dissemination efforts are reaching more liberal and moderate ears than conservative ears. So this is the proportion of legislators that thought each one of these 4 ACEs was a quote-unquote major risk factor, so 5 on the 5-point scale, for adult behavioral health conditions. So as you can see, childhood sexual abuse, the most endorsed that as a major risk factor, followed by childhood physical abuse. And then I would say notably smaller proportion identifying witnessing domestic violence as a child and childhood neglect as major risk factors. Then when we stratify these data by the ideology of the legislator, this very clear graded pattern emerges, where liberal legislators being more likely than both moderate and conservative legislators to endorse that each one of these ACEs is a major risk factor. And I'll talk a little bit about what I think this could potentially mean. So by and large, big picture, many legislators are unaware or unpersuaded by evidence about the extent to which ACEs are risk factors for adult behavioral health conditions, especially the ACEs of witnessing domestic violence as a child and childhood neglect. And the ACE science tells us that these ACEs can be detrimental ACEs and that they are major risk factors for adult behavioral health conditions. So in the study that I mentioned, published in 2008, using data from the National Comorbidity Replication Survey, witnessing domestic violence as a child accounted for approximately 12% of the population burden of adult mood, anxiety, and substance use disorders, whereas childhood physical abuse only accounted for 4%. We could probably, debate how accurate we think this is, but I think the evidence is pretty clear that, witnessing domestic violence matters, and legislators might not fully get that. And that might be some evidence we want to emphasize and communicate in a careful way. Also, the data show that, evidence about the ACE study is reaching more liberal and moderate legislators than conservative legislators. And I think, again, this just signals, ways to be thoughtful in communicating and reaching conservative legislators in ways that resonate with their worldview about ACE science. Interestingly, though, when we compared liberals and conservatives, and neither of which had heard of the ACE study, so comparing liberals who hadn't heard of the ACE study and conservatives who hadn't heard of the ACE study, liberals still remain more likely to perceive each one of those ACEs as a major risk factor. So there's an issue of persuasion, not just an issue of reach of evidence here. Shifting gears to the public opinion side. So with support from RWJF, we have a study going on where we're testing different strategies to communicate evidence about ACEs while minimizing stigma towards children and families. And this study comes out of a concern that I have, and I know some other people in the ACEs advocacy community have, around potential concerns about the portrayal of ACE science in the mainstream media, in academic discourses, and in legislative discourses as well. And the concerns, I think, can be summed up as, a lot of the ACE science is told in a story that is very doom and gloom, and it can be perceived as kind of fatalistic and deterministic. And, for some audiences, they might take in this evidence and this science and this information and might make them think that people with a lot of ACEs are damaged goods. And of course, that is not what we want. I'm also concerned, and I know others are concerned as well, that the ACE discourse doesn't always sufficiently acknowledge how structural and historical factors like poverty, community violence, racism, institutional racism contributed to elevated ACE prevalence in some socially disadvantaged communities. So often the story seems to be a little bit short-sighted and very individualistic and not talking about ACE science within the broader context of the factors that influence ACE exposure. So in this study, we're trying to figure out the best ways to communicate ACE science so that it increases public support and civic engagement for government interventions and public policies that promote healthy child development, prevent ACEs, and mitigate their consequences, but also at the same time communicate in ways that do not produce or perpetuate stigma towards children or adults who've had experienced a lot of ACEs and blaming of their parents and blaming of their families. So there are a bunch of different parts to this study, and I'm just going to talk about one little bit of this today, but just big picture. So the first phase, we wanted to systematically characterize how ACEs are being talked about. So we did a large media analysis of over 600 newspaper articles that mentioned ACEs and/or toxic stress. We've done key informant interviews with a bunch of people who engage in policy advocacy around these issues. And the next phase, which we're doing right now, we're testing different messages experimentally with the general public to see if some messages are more effective than others in cultivating the support for public policies that would address ACEs, but also do not produce, perpetuate stigma. And in the third phase, we're going to take this to the field and do this experimental messaging effectiveness trial with state legislators themselves. But right now, I'm just going to talk about this middle part and one little part of this middle part. From a public opinion survey we did in fall 2019 of 502 US adults using this thing called the GFK Knowledge Panel. It's a large, naturally representative panel of people who take surveys. All this to say, it's pretty good data. It's as good data as you can get for public opinion data, and it's pretty nationally representative. And each respondent, we gave them a very brief definition of ACEs, and that definition is here. It read, recent research has examined the effects of adverse childhood experiences on a person's health and well-being when they become an adult. ACEs include things like abuse and neglect, having a parent with a serious substance use disorder or mental illness, and witnessing domestic or community violence. So here by going to community violence, we're going a step beyond the traditional list of ACEs, expanding to another ACE, which I think the ACE community largely agrees is indeed an ACE. The risk of health and social problems in adulthood increases with the number of adverse childhood experiences that a person has. So we just gave people this information, and then we asked them a number of questions about ACEs. This is before we gave them any other message or anything at all. So we gave them this statement, and then we assessed their opinions about ACEs. So in the sample, 50%, based off that information, said that it was very important for the government to do something to prevent ACEs. Very important being operationalized as 5, 6, or 7 on a 5-point scale. Is 50% good or bad? I think that depends on your perspective and who you ask. I thought it was pretty good, obviously room for improvement, but it was higher than I had thought. And also we see that, across the board, folks do think that it's important for the government to do something to address ACEs. Not surprisingly, that more liberals are on board with that than conservatives, because conservatives often, think that government should have a smaller role in society than a larger role. So we would expect them to be less likely to strongly endorse this statement. But still, I think, over 40% across the board is pretty good. And this is a promising finding. We asked respondents the extent to which they'd be willing to pay higher taxes to address ACEs, ranging from nothing to $200. So here, this item, willingness to pay additional taxes per year to prevent ACEs in the respondents' community. And I think this is good. To me, the key finding here is that while, yes, the modal response is nothing, that's only 38% of the sample. So 62% of the people we polled were willing to pay something, $50 or more per year, to help prevent ACEs in their community. And I think that's a good thing. We asked the same question, but we flipped the end of the wording a little bit. Here we shift to the communities where the problems are most severe, as opposed to the respondent's own community. And we found that that didn't really matter. The responses were pretty much the same. So shifting gears here, we wanted to know about attribution of blame for the problems caused by ACEs. So we asked, to what extent do you think that people who have experienced a lot of ACEs are responsible or to blame for the problems they have as an adult? And 10% of the sample said that the individuals who had experienced the ACEs were very much to blame, operationalized at 4 or 5 on a 5-point scale. I would want to see that lower, but I think 10% isn't that bad. We see more conservatives and liberals or moderates endorsing that. Here we ask about parents, and this I think is potentially concerning. This is higher than what we would want to see. So 65% of the sample said that the parents of people who had experienced the ACEs were very much to blame for their children's problems. And ACE science tells us it's complex. This is not just bad parenting driving ACEs. ACEs happen in complex family and community and societal context, and it's complicated. And we don't want to see blaming of parents. An interesting finding here is when we stratify by ideology, it doesn't matter at all. So liberals, conservatives pretty much hold the same ideals around blaming parents for ACEs. So this is just one item. This is just a super tip of the iceberg. We want to explore this in much, much greater depth. But I think it's interesting food for thought information for the ACE advocacy community when we're communicating and thinking about, ways we can communicate to make sure that we're not producing, perpetuating parent blame when we're talking about ACE science. And lastly, so we asked about these quote unquote preferences for social distance from people with a lot of ACEs. So these are stigma items that have been widely used in the mental illness stigma literature, and we adapted the language for ACEs. So 20% of the sample said they would be very unwilling, 1 or 2 on a 5-point scale, to have a person with a lot of ACEs marry into their family. And when we stratify by ideology, it's non-significant, but the higher proportion of conservatives and liberal or moderates feel that way. We also asked this item about willingness to have a person with a lot of ACEs start working closely on the job. There, 15% of the sample would not be willing to do that. And we don't see significant differences again, but we see liberals being more accepting and conservatives being less willing to work closely on a job with a person who had, quote unquote, a lot of ACEs. So just wrapping it up, again, this is all very high level, very macro, very preliminary, but I think it's important data to just make sure that we are mindful and thinking about, not having unintended messaging effects when we communicate about ACE science. So just summarizing some of the main findings. One, parental blame related to ACEs might be pervasive, and it might become more pervasive as we tell more people about ACEs and how problematic they can be. Stigma towards people with high ACE scores may also be pervasive. Definitely something to keep in mind. And we see that such negative attitudes really might exist across the ideological spectrum. While they may be higher among conservative groups, they exist among liberal folks as well, and something we should be mindful of and consider. Bright side, I think public concern about ACEs and support for government intervention to address ACEs seems to be high. Just based off our very simple description of what ACEs are, we found that half the sample thought that it was very important for the government to do something. So that is a promising finding that can fuel advocacy efforts. In terms of next steps, as I mentioned, what we're doing right now and what we'll be fielding in a couple weeks, using the same thing, the GFK Knowledge Panel, we'll be randomizing people to read different evidence summaries about ACEs. So, emphasizing resilience, emphasizing health consequences, emphasizing economic costs to society, and seeing how these different ways of communicating about ACEs are associated with policy support and parental blame and stigma and these things to try to find the sweet spot in messaging and communication. So with that, I'll wrap it up. Thank you so much, and please feel free to email me with questions. Thank you.
All right. Thank you so much. So as Leslie mentioned, my name is Dr. Aditi Srivastav, and I am the Director of Research at Children's Trust of South Carolina. For those of you that may not be familiar with Children's Trust, we are an intermediary organization that works with communities and systems statewide to prevent child abuse and neglect by promoting child health and well-being. And we encourage you to connect with us and be a part of the conversation today and moving forward. And as a part of being the state prevention leader, we also lead the South Carolina Adverse Childhood Experiences Initiative. And our work in this initiative really falls under 4 key buckets. We conduct research and collect data on ACEs, positive childhood experiences, and other related topics. We mobilize community action by coaching community stakeholders on the best ways to develop plans for resilience through community coalitions. We lead prevention trainings all across the state to help our South Carolinians become more ACE informed. And we work with our community partners to advocate for evidence-based policies that can better systems that serve children and families. I'll be talking about the policy, research, and community action pieces today, and I encourage you to check out our website to learn more about our training opportunities. So as Jonathan mentioned, state legislators are a key stakeholder group when trying to understand how we can move the needle on ACEs public policy. When I was beginning my study, one of the biggest limitations that I saw in the evidence was that despite that ACEs had received a lot of recognition in public health, specifically as a root cause of a lot of the health problems that we're seeking to prevent, a lot of the public policy efforts had been very research driven. And as we know, there is a major disconnect oftentimes between researchers, advocates, and policymakers. And we know also that public policies have really been the most meaningful or comprehensive way to address behavior change, especially if we think about things like seatbelts, drunk driving and the laws that were created there. And then most recently, a lot of the successes that we've seen with smoking cessation. And so keeping that in mind and thinking about the map that Leslie presented earlier, one of the things I also noticed was that many of the state policies that had been really presented were limited in the sense that they were an unfunded mandate or resolution. So while legislators and different policymakers across the country were recognizing that ACEs were important, very few laws were focused on actually comprehensively changing the system. And so it was with that this study really began. These are the two publications that speak more in depth to the data that I'll present today. I'll focus more on the legislator perspectives, but another key part of this study was also examining the perspectives of child and family serving professionals or direct service providers that work with children and families. And so while it's important for us to understand from those who build and create policies the best ways that we can prevent ACEs, it's also especially important for us to understand from those that are often implementing these policies and programs what we should do. I encourage you to reach out if you need to get a copy of these publications. But again, I'll just be touching on one small piece of these two larger publications. So the purpose of this study was threefold. First, it was to understand political barriers and opportunities for policies and program creation and implementation around ACEs. The next, it was to really utilize the perspectives of state legislators to inform communication and advocacy strategies. So thinking about things like the extent to which research and data can really play a role in changing a legislator's opinion about an issue. And then finally, and perhaps most importantly, it focused on understanding what policies and programs legislators would recommend to address ACEs. And the screen grab here is actually the policy report that we created in response to some of the suggestions that they had about how best we should use research and data to present an issue. I chose to do a qualitative approach to my study. One of the reasons why I chose this approach was because we know that policy ideas and policy making is pretty nuanced. We know that it's not an A plus B equals C every time. And so to really capture some of those broader ideas, I felt that it was important to use the interview structure. And so I had 24 state legislators that currently serve in South Carolina participate. They, on average, provided about 60 minutes of their time, which is quite remarkable when thinking about how many competing interests and constituent services they have to tend to. And I'm happy to talk offline as to why I thought that was possible for this study. I had a second coder that assisted me in mapping the professionally transcribed excerpts from these interviews using focused qualitative techniques. The theory that helped guide this research is the multiple streams theory, which is a widely known policymaking theory. You can see here the interview questions that I used that fall under the three major constructs of this theory. But generally, the whole idea is that with problem salience, with policies and interests in policies, and the perfect storm of a conducive political climate, we can really open a window of opportunity that can help pass policies. And so I asked a lot of questions around how best we can define this topic, what are some ways in which we can address this issue of ACEs, and then what are some political barriers and considerations that we need to keep in mind when pushing forward issues around ACEs. I was really pleased to have a diverse demographic in this study to the extent that I could. The majority of South Carolina's legislature is white, male, and Republican, but we were able to get the perspectives of our female legislators, our Black legislators, and also had regional diversity. So despite South Carolina being a smaller state, one end of the state can be very different in terms of needs and community goals as opposed to the other part of the state. And we are both a rural and urban state, and so it was important to get that regional diversity as well. So now to the fun part, some of the data that I found. And so I'll really group it by the problems, the politics, and the policies. And so let's start off by learning a little bit more about what legislators know about ACEs in South Carolina. I should note that to be a part of this study, they did not have to have any previous knowledge of child-related issues, nor did they have had to work on it. And despite the sample being all over the place in terms of having interacted with child issues barely, all the way to it being a signature issue for them, every legislator was able to deduce the definition of what ACEs are. And so you can see by this quote that they were also able to identify not only ACEs that fell under the traditional 10 types of ACEs from the original ACE study, but also some of those other traumatic experiences that subsequent research has demonstrated can be equally as traumatizing and lead to poor health and social outcomes in adulthood. Similarly, all of the legislators, regardless of their background with ACEs, were immediately able to identify that intergenerational component of ACEs. But this came in two different ways. On one hand, it came from legislators that felt that children can't choose where they grow up or who their parents are, and that we really need to support parents in ensuring that children are able to have the support that they need. But on the other hand, it was almost that negative sentiment around this idea, well, back in the day, we had better childhoods and we had better parenting, and perhaps life has gotten harder, and so that's why we're seeing more ACEs amongst parents that are then transmitting that to the child. We could probably have a whole discussion as to kind of some of the values and ideologies that may be at play there. But I think what's important to take away from this finding is that all legislators recognize that parental well-being and child well-being are inextricably linked. And so it's really an opportunity for advocates to think about some of those dual generation approaches when pushing forward some of their strategies to prevent and address ACEs. And then perhaps most surprisingly for me as a public health researcher, while legislators were able to make that immediate link between experiencing ACEs and social emotional challenges in schools, mental health issues in adolescents, and even suicidal ideation, they were not able to, or were not convinced that ACEs really had a link to some of those longer chronic physical health outcomes that are especially prevalent in South Carolina, such as obesity or heart disease. And so here, we have overwhelming evidence that this link is very much present and strong. This would be an opportunity for advocates to really think about framing ACEs as a public health issue and really focusing on the ways in which it can help perhaps prevent some of the most chronic conditions that plague the state. Next, after learning a little bit about the extent to which legislators knew about ACEs, we moved into the best ways in which we can increase the importance of ACEs as a policy issue. And so here we spent some time talking about terminology. I was especially interested in hearing from legislators about whether they like the term childhood trauma or ACEs better. As we see even in our field, we use these interchangeably or slightly differently depending on the sector that we're representing. What was very interesting here was that legislators generally found childhood trauma and ACEs to be synonymous, but that they had different implications. On one hand, some legislators felt that calling it childhood trauma was calling it what it is, a very, very severe issue that needs to be addressed right away. So they spoke to the emotional component that that term can provide to legislators that may not be, may not have much knowledge about this issue. But on the other hand, there were legislators that said, well, trauma only happens to, certain people or a small population of people. But when you use the term ACEs, it makes it relatable. And so here, it really speaks to kind of that balance that all of us have to make in this field all the time, right? On one hand, we know that ACEs are common. They're likely to happen in all different types of communities. But we also know that equity piece of it as well, and that we have to recognize that certain populations or certain communities may need more to mitigate or address the effects of ACEs. And so ultimately here, the recommendation that came out was to really use these terms strategically depending on your audience with legislators. Another suggestion that legislators had to really increase the salience of the issue of ACEs as a policy issue was to make it a solvable problem. So for us, large, complex issues such as poverty, violence, ACEs are easy to understand because we're in it all of the time. But policymaking, unfortunately, cannot comprehensively address a complex issue like that. And so one of the biggest suggestions that many legislators had was ACEs is overwhelming. Give me one or two ways in which I can immediately address parts of the issue. Really break it down so that it's something that is achievable. A lot of them talked about how having short-term wins was important, because being able to go back to their district and say that they were able to do something in their time as a legislator was also important. This also spoke to, that the group of legislators that still don't think or are convinced that ACEs are a policy issue. A lot commented on perhaps this being more of a cultural issue, and as we all know, that is not the case. And so perhaps there's an opportunity there for advocates to really bring forward the science and shed light on the ways in which policies and practices have actually increased exposure to ACEs amongst children and family over the last several years. And then they also recommended not leading with prevention. And so while prevention is a very important concept to many of us in public health and in other fields that are focused on changing behaviors and improving the lives of children and families, it is not sexy enough to pass policies. And so one of the things that many legislators said was, while prevention is important and we recognize that there may be some cost savings, it cannot be the main reason why I support a bill or an idea. And so really thinking about other ways in which to frame the issue will be especially important to really get it on the political agenda. And then finally, one of the ways in which legislators recommended elevating the issue of ACEs was to embed it in a hot topic. And so when I conducted this study, the three issues that they found most relatable to ACEs was this idea of mental health in schools, as at that time legislators were looking at ways in which to increase mental health clinicians in our public schools, the opioid epidemic, and education reform. And so something to keep in mind here is that the policy agenda changes all of the time. And so perhaps a hot topic a year from now may be very different, but that there's certainly an opportunity to embed what we know about ACEs science into some of the related issues that may be coming up on the policy agenda. And so after we learned a little bit about what they knew about ACEs and then their suggestions for how we can elevate it as an issue, we then moved into perhaps the most interesting part of the study, which is how can we address ACEs through public policy? And so here I really asked legislators to think about things like, do you think ACEs are solvable? Do you think a child can bounce back from experiencing ACEs? Do you think that resilience is an innate capability, or is it something that can be learned through time and support? And so through those discussions, three protective factors emerged. Generally speaking, legislators all thought that resilience can be built over time, but that some children may be more innately resilient than others. And so there's certainly an opportunity there to educate them on the ways in which some of our social determinants of health can absolutely influence whether or not a child is able to be resilient in a healthy manner. The three protective factors that I've listed here, I attempted to keep in their language to really preserve the authenticity about how they think about these protective things. But you can also quickly make parallels to some of these protective factors with what we know works in the literature. So these three protective factors were loving, consistent, nurturing relationships, safe home environments, and opportunities to thrive. So these are the three key things that legislators felt were the ways in which we can respond to ACEs and prevent them or address them from occurring altogether. After we talked a little bit about ACEs and resilience, I asked them probably one of their favorite questions, which was, if you had a magic wand, what would be some policies and practices that you would recommend? And so the next couple of slides will talk about these suggestions, and they are organized by the protective factors that they identified. So to promote loving, consistent, and nurturing relationships, legislators recommended increasing state funding for mentoring programs after school and in faith-based settings. A lot of legislators recognize that perhaps community-based organizations are the most appropriate for helping promote these types of relationships because on a state level, we may not have as many great grassroots connections. They also suggested improving the education system by hiring more support staff, increasing pay for teachers, and seeking consistency and quality of education. So most legislators recognize that the educational setting is probably one of the most important settings for a child that may have experienced adversity or ACEs to be able to have that nurturing environment. And then finally, several suggested that we use schools as a family resource center to ensure that families have the services and the care that they need so that they can provide a positive relationship and environment in the home. And so you can see here 2 examples of quotations that reflect some of the policy strategies. And I might note that there were many, many other strategies that they recommended. These were probably the most common across all of the legislators that participated. Next, to promote a safe home environment, which they really defined as reducing exposure to violence in the home and injury in the home. Some of the suggestions that came out here is to invest in higher quality group homes and foster care options. So many legislators commented on the system not being able to provide necessarily a positive transition space if a child is removed from the home or if they have to be put into foster care, and that perhaps could be traumatizing. They suggested expanding evidence-based parenting programs that encourage positive parent-child interactions. Many legislators were in full support of providing parental supports as they believed that parents want to be good parents. And we did see more of this in some of the more liberal-leaning legislators, but generally speaking, this was a theme that came up across the board. Many legislators across the aisle also talked about universal home visiting options. Specifically, nurse-family partnership was one that came up continually. And many of them felt that this should be a universal option for all first-time parents because everybody needs help with parenting. And then finally, several legislators recognized that South Carolina is among the top 5 in terms of violence against women, and perhaps more could be done there to reduce domestic violence as they started to make the link between domestic violence and its effects on the child. And so really thinking about the ways in which we can develop more laws that prevent child injury and exposure to violence in the home. They did recognize that certain efforts have occurred to do this, including creating the Office of a Child Advocate, which is to really be a check on all of our child and family serving systems, as well as some of the recent legislative successes around child passenger safety and safe sleep. And here you could see 2 examples of quotes, one focusing on the home visiting program and really making that universally available, as well as their desire to provide parents with the support that they need. And then finally, the last protective factor, I think, was the most broad, but generally speaking, legislators across the aisle really felt that every family should be able to meet the needs of their child. And it was the term needs that varied. For some of our more conservative legislators, they were focused more on those basic needs, such as transportation, affordable housing, providing enough food to eat. While for our Democratic legislators, they focused more comprehensively on access to affordable care or quality housing. But generally speaking, it touched on those buckets. And so you can see here that they suggested many different ways in which we can provide families an opportunity to thrive, starting off by expanding access to affordable healthcare options, providing workforce readiness programs for single parents, offering affordable, high-quality childcare options, including universal 3K, reforming criminal justice policies to encourage unification of parents with children and work opportunities, and then finally, creating data sharing system to hold state systems accountable. So the criminal justice suggestion came specifically from Black legislators, as they've been doing a lot of work around ban the box and other criminal justice reform policies. And the data sharing really came from Republican legislators that were interested in holding current state systems that serve children and families accountable for ensuring that their services are better aligned and that we're able to really see outcomes from the work that we're doing. And you can see that that is really reflected on the quote at the bottom of this slide here. And at the top, I provided an example of affordable health care. Not surprisingly, our Democratic legislators immediately made the link between ACEs and the missed opportunity that we did not expand Medicaid. So this study was especially beneficial to really helping shed light on the ways in which we can better frame ACE policies, specifically to increase their urgency on the policy agenda, as we know that we're often competing with many other issues. It also provided insight on aspects of ACEs and resilience that have gained traction with legislators. And I should note that this was conducted almost a year and a half ago, and in that time, I'm sure that there's been much more visibility, and there has probably been much more traction around ACEs that may not have been captured in the study. It presents political barriers and opportunities to passing ACEs policies. I didn't touch on this too in depth here, but certainly encourage you to take a look at the publications, which talks a little bit more about those barriers and opportunities. And then perhaps most importantly, it highlighted potential communications and advocacy considerations when we talk about the issue of ACEs and resilience on a state level. So one of the unique aspects of being a researcher in a community-based settings is that I often get to use my research to help inform some of the great work that we're doing in South Carolina. And so I just briefly wanted to end by providing 2 examples by the way in which this research has helped inform some of our other work. The first is we recently held a data release event for Kids Count, which, if you are all not familiar, is a project of the Annie E. Casey Foundation that measures the state of well-being of children and families across the country. And this past year, we had 4 legislators come speak about the data that was released. And it was really incredible to see them make the connections between ACEs science and what the data was showing. And there was actually one question in particular that we asked them around how this data could be changed based on different policy proposals. And there were many instances where the legislators referred to some of the ACEs science and how their policy proposals can help address that and move the needle on child well-being. And since this study, it's really also been incredible to have champions in the legislature now that are coming with that lens of ACEs informed or trauma informed when thinking about these larger ticket items such as education reform or mental health in schools. And then another way in which that I've been able to incorporate this is through our work with community coalitions. We are using the Empower Action model, which is a model that we've created that helps communities build a plan for action around addressing and preventing ACEs. And one of the key components of this model is to really consider the multi-level influence that can affect a child's health and well-being, with one of those levels being the policy level. And so one of the ways in which that we've been able to incorporate this study is in the coaching or planning process of this model. So we're currently working with 3 coalitions, and we have community coaches that are employed at Children's Trust that actually help build the capacity of the coalition backbone agency to be able to lead discussions around this model. And so one of the key tools around that is our Ready, Set, Go guide, which is our Empower Action Model planning guide, in which we provided a lot of guiding questions and worksheets to think about the different ways in which we can influence and prevent ACEs. One resource in there are our policy checklists, where we provide questions for community coalitions to really think about, you know, are there policies and practices in place, or are there things that we could be advocating for that really will change public policies to better address well-being and prevent ACEs? And so I was able to use a lot of the recommendations that came out of this study to help build that resource for the Empower Action model. So with that, I wanted to end with probably one of my favorite quotes from the study. I think that this quote is a reminder that when sometimes the work can get disheartening, we have to keep going because there's a lot of great work going on. And it's also, this quote is also a reminder to me that while the policymaking process might be slow and maybe not as fast as we'd like, or maybe it takes a little more convincing than we like, you know, legislators, they want to do good and they want to do what's right. And so here is what I'll leave you with. This was a quote from one of the legislators that participated. And he said, Oh yeah, our state motto, of course. It is about children and resilience. While I breathe, I hope. I'm always an optimist. So I hope that all of you continue to be an optimist as we move more public policies forward to really ensure that all children and families have what they need to be successful and thrive. And with that, I'll leave my information here and hand it over to Wendy.
Wendy, you'll need to unmute yourself. Wendy, we are not able to hear you. You're going to have to unmute yourself or chat to me, and we'll see if we can help you out.
Are you able to hear me now?
Yes, now we can hear you.
Oh, technology. Well, thank you. Good afternoon, everyone. I am Wendy Ellis, and I'm the founding director of the Center for Community Resilience at the George Washington University. And I want to give you a little bit of background about our work. We are entering into our 5th year, and the Center for Community Resilience provides a solutions-based, innovative approach to addressing adverse childhood experiences in the context of adverse community environments, or what we have coined the pair of ACEs. And so our work is rooted in really thinking about not only what is happening at the individual level, but what is happening at the community level as well, that either exacerbates adversity, childhood adversity, or community adversity. And so when we think about this work, the communities that we're working with across the country span 10 states plus the District of Columbia, 45 organizations that are successfully implementing our Building Community Resilience process, which applies an equity lens to childhood and community well-being. So to give you an idea of who drives this work, because I did notice in the chat function, there was a question with regard to who typically are really good backbone agencies to take up this work. If you look at the logos here, you'll see there are a wide range of partners who really take on this work, and they work together as a coalition. What we have found is that in the 5 years of implementing this, as that there really isn't any one type of organization that can drive this work. There are multiple partners that can either work concertedly together as co-leaders or using a co-chair type of driver in the work. So when you think about, if you look at this work, even in Dallas, we have the shared leadership between the City of Dallas as well as the county health department. Many of these states, in fact, 5 of these sites here, it is the county health department that is driving the work, whereas others, they are working with a collection of social service and health care entities, as well as state level health departments, as well, and health and social and health services departments. So you can see that, you know, despite what sector you may come from, that doesn't necessarily limit who can lead this work. But when we talked about this work in the very beginning, we were very much focused on ACEs because we had health and social services partners at the table. But the more and more we became engaged with community, it became abundantly clear that we had to be able to talk about equity. We had to be able to talk about structural issues, structural racism explicitly, if we were going to be effective, both in addressing the underlying drivers of adversity, but also if we were authentically engaging with our community partners and unable to have explicit conversations and acknowledgement about the effects of structural racism in our communities, then as one individual told us in community, we might as well go home. And so that is how, you know, this group of collaboratives from across the country that first started very tightly focused on ACEs and in making the pathway to resilience became focused on equity and understanding that inequity drives many of the traumas that we see in our communities, and the pathway to resilience is certainly going to pass through equity. And so helping our teams to understand that or be able to communicate that effectively at multiple levels, not just at the community level, but across multiple sectors as well as in the policy arena, have become abundantly important for the work that we do. And just to give you an idea of just how varied that work is and how we understand ACEs to be, or how they express themselves from community to community, I do want to give you just an example of some of the work that is going on across the communities and how they broadly interpret not only adverse childhood experiences, but also these adverse community environments. So in Louisville, Kentucky, they are looking at evictions as a consequence of gentrification, recognizing that the loss of space, the loss of place, is also a trauma that is inflicted not just on adults, but certainly on children. In Cambridge, Massachusetts, they are looking at the suicidality of men of color from 18 to 24 and partnering with workforce development as a means to provide that resilience, that buffer that's needed for individuals who may be teetering on the edges of society. In North Carolina, we're working with 3 counties that are looking at building their own ACEs coalitions that have started in schools and moving that out to a community level coalition that eventually sparks a trauma-informed movement. In Washington State, we're working with tribal entities that are looking at driving a tribal birth justice program to reduce infant mortality and maternal mortality. In Washington, D.C., we've worked with community members that are looking at the stressors that are brought on by interactions with Metropolitan Police as a major adversity that's going on, not just for adults, but also for children in the community. And in Dallas, Texas, we're working with the county health department as well as with the city department of social services, as well as their community partners, to address the effects of human trafficking. So you can see that these issues that we begin to address when we really work engaging with community in a very effective and authentic way, that it goes beyond those the qualifications of what has been historically defined as the adverse childhood experiences. But then when you look at how we frame this, you heard me talk about the pair of ACEs. So when you think about how we frame this, it was intentionally framed in a way that these other topics could come up that go outside of the 10 adverse childhood experiences, but definitely have a long-term effect on health and are definitely affecting our children and our communities. And that's really thinking about using the tree analogy here. So these adverse childhood experiences are like the branches and the leaves on the trees, the things that we can easily, readily assess, whether that's assessing a child in the classroom or a mother in a postnatal exam with a physician. But what we don't readily see are these effects that are in the root, what's in the soil of the community, understanding the lack of economic mobility, social capital, poor housing and quality of affordability, gentrification, violence, community tensions. These things either contribute to these adverse childhood experiences and oftentimes exacerbate them. But when we also reframe this to think about these are outcomes, these adverse childhood experiences are outcomes that are associated with the policies and practices that are inside the soil, that are buried in the soil, that helps us to understand that if we only think about these outcomes, that we are not going to actually provide folks the ability to access resilience, because resilience is a process, not a static state of being, then we're really not providing those buffers and supports on a permanent basis that allow individuals to bounce back. And one of the things that I think is important too when we talk about the equity framing around this is to help understand that if we only use the framing of resilience to say that, you know, we want to provide supports and buffers for individuals to bounce back, then that really negates the idea that we're truly in an equity frame here, because we have to recognize that many of the communities, many that are suffering from these pair of ACEs, are starting from a point of inequity. So to merely bounce them back to that start is not truly building equity. So we understand that when we frame our work around resilience, we're talking about providing supports and buffers so that they not only can bounce back from an acute stressor, but that we're also addressing these long-term chronic stressors so that they actually have access to thrive. So how do we frame the conversation around equity? How do we begin to have a collective understanding of historical trauma on our communities? Well, when I first started working around ACEs almost 20 years ago, I can remember having conversations with legislators in Olympia, Washington, and the reticence to even to bring up adverse childhood experiences. No one wanted to talk about childhood abuse. No one wanted to talk about neglect. And yet we were able to normalize that conversation, not only through the science, but through the lived experience, through the stories, and pairing narrative with data to help legislators and others actually see themselves in the work. Similarly, now in 2020, we are trying our best to normalize the conversation around equity. And one of the first things we're doing is actually taking a step back to really understand what are the underpinnings, the historical underpinnings of inequity and trauma in our communities. And so this is one of the tools that will be included in our upcoming equity tool to help people understand the historical narrative around the structural racism that was built in our country to explicitly drive inequity and trauma. And while that may have been directed at people of color, certainly the opioid crisis, the widening disparity with regard to economic mobility, the poverty levels that are rising regardless of race, helps us to understand that these policies are affecting all of us, not just certain people of color. And to give you an example of just how these effects of policy have laid out and can still be measured in 2020, even things that occurred back in 1700s, I want to pick one policy just to kind of get us through this timeline here, and thinking about three main sectors of our community that actually drive a lot of the outcomes that we see. So if you see in the middle of this timeline here, I have at the New Deal, I have the New Deal housing initiatives and redlining, and how we can talk about some of the areas of chronic poverty and using data from our own communities to begin to understand how we come to express such areas of concentrated poverty and inequity. And so when we think about the history of the New Deal policies that really subsidize and incentivize spatial segregation in our communities, and the vestiges of which can still be measured today. And so understanding that piece of it, we have developed a tool to help people to understand that, you can take your local redlining maps and lay that over areas of concentrated poverty and other negative public health outcomes and see that they coexist. That is not by accident, that is completely by design. And so understanding that even those areas of concentrated poverty also carry the greatest burden of chronic disease and oftentimes also carry the greatest burden of ACEs. And so then when we also look at connecting public policy to inequitable education outcomes, we can begin to see how the distribution of resources, application of discipline, and access to resources and supports within schools differ by the population, differ by economic backgrounds. Then we understand that our schools, many times in our communities, are a pair of ACEs themselves. They are adverse childhood experiences and they're adverse community environments based upon the underfunded or under-resourced ability to provide the buffers for the children that actually need it the most. And so we use this to help understand also how we can connect criminal justice policies to these community characteristics and inequity. And why does this matter with criminal justice? Is because for children of color, parental incarceration is one of the most common ACEs. When we look here in Washington, D.C., 10,000 children in Washington, D.C. have a parent who has experienced parental incarceration. So understanding, even when you look at this across races, the disproportionality of incarceration, we can understand the disproportionality of this adverse childhood experience across races. So when we talk about the pair of ACEs, again, reminding ourselves that this is the framing, that we're not just going to look at the adverse childhood experience and program or diagnose and treat our way out of ACEs, that we really do have to think about the policies and practices that are driving these outcomes that we see. And so that is the building community resilience process that we use in the work that we're doing across the country, is creating this shared understanding around the narrative, the resilience narrative of ACEs in our community, and really understanding the historical underpinnings of racism, structural racism, so that we can begin to understand the true community experience of ACEs and not just limit it to those 10 ACEs. And then also when we talk about the state of readiness, is that we go beyond just looking at provider capacity and capability and trying to build supports, but it's also being very strategic about identifying the policy and program gaps and providing an opportunity to address implicit bias. And then when we look at and we involve our cross-sector partners, we're also involving them not only to how do we connect to resources and how do we create community and political partnerships, but how are we as a collective creating equitable access to practice, and how are we advocating for policy change? Again, community is at the center of the work that we do. As you heard me talk about many of the topics that we are addressing across the country, those did not come from just merely examining systems data, whether that was health department data, whether that was provider data, but that was with a process of discovery with our community members that are there at the center of the table. So through that, we're able to prioritize our issues and co-create solutions. And I will say that in the policy and advocacy sphere, having community members at the table, they are the most effective advocates in this work. So speaking of advocacy, everything that we do in the work of building community resilience is around three main P's: practice, program, and policy. And even in today's fractious political environment, we work across both sides of the aisles. This is not a partisan issue. Trauma is affecting everyone. And certainly the opioid crisis has provided that opportunity for us to reach across into urban communities as well as into rural communities with Republicans as well as Democrats. And so one of the things that I want to highlight to all of you who think that, talking about racism or talking about equity is the third rail of American politics, it is, it could be, but it's all about approach. And so one of our teams from St. Louis, the Alive and Well Communities, successfully met with Senator Roy Blunt from Missouri and introduced language to really dedicate to incentivize understanding the connection between birth outcomes for African American women that have been connected to the trauma associated with racism. And so the actual language that went into the FY 2020 for appropriations for labor, health, and human services really directs each department of the Health and Human Services to submit a report to the committee, providing an update on the department's implementation of their action plan to reduce racial and ethnic disparities. Again, remember, this is very much tied to ACEs, understanding that the differences, these inequities themselves are driving ACEs disproportionately in communities of color. And so while I share that, it may sound daunting to enter into these conversations in community. I will show you, as I showed you on that map, there are 10 other communities across this country in red states and blue states that are doing it. And so we're happy to share our newest tool that actually is based on the work that we've been doing for the last 5 years, not only in talking about ACEs and talking about ACEs policy, but really getting to the root of what's driving adversity, not just at the individual level, but at the community level. So our Fostering Equity Toolkit provides many of the tools and resources that our communities have been using, some of which we've designed novelty through BCR, but a lot of them are a number of organizations across the country have been using them, but using them in a piecemeal fashion. And so with our partners, we are sharing some of the work that they've done on the ground with regard to equity, and I would encourage all of you who want to make a difference with regard to ACEs to join us too. I think together we will all not only reduce adversity, but we will build a resilient nation. So thank you.
Thank you so much, Wendy, and Jonathan and Aditi. We are going to open this up for questions in just a moment. And so just want to remind people that you can keep asking the questions through either the chat box or the question box. Let me start off with a question. I think that Aditi, Wendy, you did speak to, but other panelists and panelists, if you'll unmute yourself so that you can all speak to the questions, that would be great. But the question from one of the attendees is, how do we get legislators to care about adverse community experiences? So who would like to take a first pass at that? Or Wendy, would you like to add anything else?
Yeah. I mean, I think one of the things is, and it's, it's communications 101. You meet your audience where they are. And so, certainly when our teams were meeting with Senator Roy Blunt, they weren't just immediately diving into, what's happening in St. Louis or what's happening in Kansas City, but also painting the picture of how that's relevant in our rural communities as well. Many of you may have even seen today, there was a New York Times article with regard to the state of infrastructure in rural America and how that impacts not just the transportation of goods, which obviously affects economic mobility for these families, but thinking about how that affects transportation going from school to school. And so, really doing our homework with regard to what is going to be resonant to not only that lawmaker, but to their constituency, and what are the real impacts of adverse community environments. I think that that's how we've been able to be relevant to the lawmaker themselves. And it's not so much how do we make them care, it is what do they care about and what is relevant to their community, so that we can begin to start the conversation with regard to equity. And one of the points that I'd like to make also with regard to discussing the adverse community environments is that you have to also be able to understand that there are many lines that divide us. So you've heard me talk about the urban versus rural, but there's also, education, there's income, there's religion. So really beginning to understand and do your homework with regard to what's going to be relevant to that lawmaker is really how we've been able to frame the adverse community environment, frame the pair of ACEs in a way where they feel like that's something that they act upon.
Great, thank you, Wendy. Aditi and/or Jonathan, did you want to add anything about your thoughts?
I would just add that generally speaking, in our work with a lot of our trainings and reaching a diverse audience of people, whether it is social workers or just a concerned parent, the frame of ACEs has really just put a nice kind of bow on something that we already knew existed for a long time. And so one of the things that we've found is that ACEs has really helped in getting people to understand that concept of social determinants, or that the ways in which a child grows up is absolutely influenced by the social environmental factors around them. And so even just talking about, those social environmental factors in early childhood and the general sympathy that legislators have for children not being able to choose what they're born into has really been able to open up some discussions that we wouldn't otherwise be able to delve into.
All right.
And this is Jonathan. I mean, I'll just,
go ahead, Jonathan.
I think this applies to convincing legislators of a wide range of things. But the more that you can bring in local data and cast an issue in terms of a legislator's constituency and the people they represent, the better. And also, for many legislators, and in my research, we found especially more conservative legislators, telling a story in dollars and cents and talking about economic impact locally can be a persuasive communication strategy.
Great, thank you. And just a couple logistics. One of the attendees asked if we could put up the webinar registration that was on the last slide. Wendy's already sent that out to all attendees, and we can also follow up with sending that out to everyone who registered for the conference, for the webinar. All right, so here's a question for all of you. Can each of you detail a statewide legislative policy that has been enacted that has actually made an impact? And also, attendees, feel free, if you are aware of things, to answer other attendees' questions, to type those into the chat box if you have thoughts on that. But anyone you want to bring in with an answer to that question? A statewide legislative policy that's been enacted that has made an impact.
So this is Wendy. One of the things, I live in Washington, D.C., and we often operate as both a state and a city. And our council has recently passed 2 pieces of legislation that really put into place a permanent infrastructure for dealing with adversity, with the pair of ACEs. And so Washington, D.C. was one of the 100 resilient cities that was in the past supported by the Rockefeller Foundation. And the 100 resilient cities, part of that grant is creating a resilience cabinet, which many cities also have, but they're using their resilience cabinet as a means by which to address the cross-cutting issues in the city. And so City Council member Brandon Todd, who we've worked with very closely on the ACEs and the trauma work here in the DC network, sponsored both the permanent establishment of the Office of Urban Resilience as a means by which to begin to work across multiple sectors to deal with the city's entrenched adversity. The second piece of legislation that he passed to support that was then the establishment of ACEs legislation that would begin to define the city's role specifically in addressing adverse childhood experiences. The first of which is to establish a number of, or to actually reinforce a number of pilots that have been conducted in the city to address particularly the pair of ACEs in Ward 7 and Ward 8. And so, that took us about 3 years of working with legislators, council members, and really helping them to understand the public health aspect of resilience, because still many times city leaders think of resilience as something that is seen through the emergency preparedness and disaster literature, as opposed to something that's public health and preventive. And so having those 2 structures, a permanent office that sits in the city that is overseeing and sees as its charge this public health approach to ACEs, and then having this second mechanism that specifically talks to what we will do, how we will respond as a city with regards to where resources will be allocated and how, I think is a good example of what you can do, whether that's at the city or the state level. And again, I thought it was important to highlight this because while we are DC as a city, this was operating at the state level as far as the city is concerned.
Great, thank you, Wendy. And there's some great suggestions coming, some great ideas coming in from attendees too that you can't all see, but Read to Succeed, some of the work in Alaska. We will make sure that these are shared to all of you. I do want to make sure we get to a few other questions, and here's one about metrics. There's a movement to simplify metrics. Are you advocating for any common set of measures on equity, resilience, and ACEs that would benefit all communities to measure their status, progress? And in parens, I'm a fan of the well-being in the nation or WIN measures. So panelists, any thoughts on that?
I hate being the only one to talk. I do want to give Aditi or Jonathan a chance to talk, but that is a part of our work that we've developed specific measures in the Resilience Catalyst work. And actually those measures are not novel measures. We were very determined to create more of a dashboard that's already based upon public health outcomes that are often measured in the county health rankings and Healthy People 2020. But then also going beyond that to get to these systems measures that actually are associated with a lot of the community characteristics that we look at. So that's part of what we will cover in the Fostering Equity webinar, but it's also the latest paper that we'll have out to really understand how you can look across already common measures, but putting them in one dashboard to begin to see across particularly housing, public education, and criminal justice, how these systems indicators are associated with community characteristics such as economic mobility, housing affordability, and how then that is connected to the population health outcomes that we see, and particularly the pair of ACEs.
Thank you, Wendy. And I do want to just read a comment from our wonderful colleague, Aditi Srivastav, who said, encourage measures measures that go beyond WIN to include data from the community and families and not just census and birth and death records. So thank you, Christy. Jonathan or Aditi, did you want to add anything?
So I actually wanted to go back to the previous question about possible statewide policy measures and to kind of reinforce what Wendy said, that it takes time not only to even get a policy on the agenda, but then to actually enact it. But there are two examples I thought of, one on a state level that I mentioned in my presentation, and that was the Office of the Child Advocate. That is mirrored by a lot of other Office of Child Advocates across the country. But the intent here is to really ensure that the systems that are currently serving children, whether it is prevention or treatment oriented, are doing that well. And so it's in its first year since that policy was passed. And so I think that that's going to be a real opportunity to see how we can better align systems that serve children and families in South Carolina. And then on a local level, one of our coalitions, which is named Resilient Richland, they've been working with the local school district and have instituted school resiliency teams, which is more of a local policy change, in which they're providing staff members that are exclusively focused on the social behavioral well-being of children in that school. And so as you can imagine, if that is their only focus and they don't have the same teaching load or administrative duties, we're very excited to see kind of what the benefits of that pilot will be. And I know that the school district is really interested in hopefully making that a universal policy and approach once we do have the evaluation coming in. And then in terms of some of the outcomes, so as an intermediary, we're looking more at outcomes that measure things like community capacity and community collaboration. I'm happy to talk more about what our evaluation looks like for some of those pieces. So we've created some tools in partnership with Chapin Hall at the University of Chicago, as well as with the HOPE group, taking a look at community protective factors, community assets as particular outcomes to measure change. And then of course, we're also looking at local data such as child maltreatment data. So we're entering into a data sharing agreement with our Department of Social Services to really see if we can move the needle on the ways in which children are entering DSS. And then we are also looking at kids count data and other larger, as one of the participants mentioned, more large census related data that is certainly important but may not necessarily provide the contextualized insight that we need.
Okay, Jonathan, I'm going to give, go ahead. I'm going to give you the last word, Jonathan, because we're running down our clock.
All right, and this is also in response to the previous question about state policies. And just one very concrete thing is increasing the minimum wage. So there have been a number of studies that have looked at increases in the minimum wage and how that is associated with reductions in child maltreatment rates. So I think that's just one very concrete policy with very concrete outcomes. There is a long history of child maltreatment research and child maltreatment data being collected, and it uses a different language of ACEs, but of course these are ACEs. And there's a rich body of research studying state policy changes and child maltreatment rates. So the report I mentioned by the National Conference of State Legislators synthesizes some of that evidence and has such policy recommendations.
Great, thank you. And I apologize for the background sound that's coming from my office. We do have some activity going outside the window here, but we have come to the end of our time. And So I know there's some questions out there that have not been answered. Hopefully you can either direct those to the panelists or to me, and I'll make sure that they get out to the panelists. We will be sending follow-up information with a link to the recorded webinar to everyone who registered. And I want to thank all of you who took time out of your day to be part of this, and really hope that we can continue to find ways to work together on policy and advocacy that address ACEs and trauma. And I want to deeply, deeply thank the panelists, Jonathan Purtle, Aditi Srivastav, and Wendy Ellis, and my colleague Claire Reedy, who's been here at my side. And also, of course, our co-sponsors again. Thank you, everybody, and have a great rest of your day.